Hello, everybody. How you guys doing? Everybody good? So, yeah, we do have this postperennial, at least I would, but I'm standing up here, so it's a little bit easier for me. Now, I would say that I am excited to give this talk. I don't know if we got the clicker or anything like that. Do we have the clicker? No, so I'm gonna be still. I did have a lab because I like to move and like to engage, and so, but I'm kind of here, so hopefully you bear with me. And I would say I'm almost excited as I was during the opening party when the DJ played my song. No, I'm just kidding. So I am going to be talking about a headache in the adult patient. And I'm very, let's go here. Oh, it's over here.
Click on the slide again, and then now
I can't
try to move it forward.
There we go. Awesome, thank you.
Yeah.
Of my disclosures, I think the most important disclosure, the other ones don't, the most important is that we are going to discuss treatments. I will discuss treatments that's going to be off-label because there are not a lot of on-label treatments for headache disorders in the ED that we see in the ED. So that's the most relevant. The other ones are irrelevant, but that's the most relevant disclosure that I have. My objectives are going to be very similar in the sense that it is still important to identify red and green flags when a patient with headache disease presents in the emergency department. I want to appreciate some of the I want us all to appreciate some of the select dangerous causes of secondary headache. So I'll actually expand upon what Dr. Shea did. But more so in the adults. And then a brief exploration of the treatment of migraine in the emergency department. So I'm going to start with a case. And with this case, we have a 32-year-old who has occasional moderate headaches here and there. It's occurring during times of stress and everything. I just put my lab on so that I can move a little bit. But it does occur during times of stress. Let me know if the echoes come that may contribute, please. Yeah. But they had a headache, and this headache occurred, it's a very severe headache, and occurred right at or just about on orgasm. Figure we talk about sex a little bit here and kind of keep us awake a little bit. This is his second episode, and the first lasted for about an hour, but this one continued. It's almost 3 hours, and it's really stopped him from going to sleep, thus his presentation to the emergency department. Now, while his previous headache attack was severe, and it caused him to hesitate to have sex, he said it really didn't last this long, which is really concerning to him. And now he really wants to abstain from sex, which is concerning to his wife. And he has been tried on beta blockers, but without success. And his PCP ordered a CT, and that's normal, but his wife really is scared that he has an aneurysm. She has a question about aneurysm because his father died from one. So when we look at steps of a headache diagnosis, it's really important, especially in the ED, to rule out secondary headache. And now the headache history is very, very important, as well as the examination. But due to the time length of my discussion, I won't be going too much in detail with that. But we are going to explore red and green flags. Now, if you've seen this, I just have a little red flag. I thought about Snoop, I thought about Snoopy and everything, but I just have a little red flag. And as Dr. Chase said, this is really expanded. We started off with Snoop, okay? And she went through this very much in depth. I won't go too much in depth, but to say that it's very, very similar. But as she pointed out, we have gone from Snoop, it was Snoop P4, then Snoop P5, then Snoop into P4, but now it's going up to Snoop 10, and the Snoop 10 actually demonstrates demonstrates both the red flags and the orange flags. And one of the things when we talked about this, I didn't go all because she did such a great job in doing that, but as we are doing this interwoven case with the extra P, which was one of them was post-traumatic. So when I think of people, the P's the N that was incorporated, that wasn't in an original Snoop is the neoplasm. So if someone has a history of neoplasm, then we definitely want to it calls for further investigation. And then we talked about if someone has immune disease or pathology of immune system, so they may have more risk for systemic disease when it comes to infections or painkillers or other drugs at the onset. Now, again, this was covered earlier, so I'm just going through this a bit brief. Now, there are also green flags. So I did want to cover this. So the green flags indicates that headaches are more likely to be primary than secondary. And so if the current headache has persisted since childhood, if it's occurred in temporal relationship with the menstrual cycle, if the patient has headache-free days, if the family close members have the same type of headache phenotype, and the headache has stopped or occurred about a week ago, or for a week. Now, what's important is, though, even though we have these green flags, we must always investigate for red flags. And if people have both green and red flags, we still want to investigate, and it's still more investigation is warranted. So I want to talk about thunderclap headache. And when I think about thunderclap headache, I think about, really think a lot about vascular, right? So kind of, and you see this kind of in the vascular realm. You can think about structural problems. You can also think about infection. And then there's idiopathic types of thunderclap headache as well. And so we're going to review some of this because our patient that came into the ED, had this abrupt, right? It went severe very quickly. It's just a thunderclap. So we're going to review some of those. So subarachnoid hemorrhage, 90% of people present with a headache. And the ED accounts for about 25% of the worst headache, and then about less than 20% may not have headache, or the headache gradually increases, or the symptoms are mild, or is overshadowed by the other symptoms. This is a very fatal disease, right? Then the aneurysm subarachnoid hemorrhage accounts for about 80% of the non-traumatic subarachnoid hemorrhages. And this accounts for 3% of strokes, but 5% of all stroke deaths. And even in the survivors, about 10 to 20% are functionally dependent, and then reduced quality of life in about 60% of people. There are risk factors that we think about. We have risk factors from on the patient side, risk factors on the aneurysm side. So patient risk factors, cigarette smoking, hypertension, race, ethnicity, family history, female, just a little bit more than males, just a little bit more, 1.6 to 1, and age over 60. And some of the aneurysm, essentially when we look at the aneurysms here, it's basically the size, the location, and how many. That is a factor for risk factors. And then if we're following up, then there's actually growth during that follow-up imaging. When we look at diagnostics of aneurysm subarachnoid hemorrhages, the CT, less than 6 hours is basically the bottom line, is that these modern third-generation CTs are extremely sensitive in identifying subarachnoid hemorrhage when it's carried out within 6 hours of the headache onset and interpreted by a qualified radiologist. CSF xanthochromia is 2 weeks. Again, the probability is very high if you catch it and do a CSF analysis in 2 weeks. It starts to drop off in 3 weeks and 4, but essentially a negative CT and negative CSF is sufficient enough to rule out subarachnoid hemorrhage. Now, this is all has happened in the past. Where have we gone? So published last year was the shifts in diagnostic testing of the headache in the emergency department. And these investigators they were looking at subarachnoid hemorrhage and bacterial meningitis. And what they saw was that between the years of 2015 and 2021, CT cerebral angiography use increased 6 times that of lumbar puncture, with a 33% increase in the detection of unruptured aneurysms, and with no significant change of misdiagnosis of subarachnoid hemorrhage. So there was, or a bacterial meningitis. So there was misdiagnosis. It was subarachnoid hemorrhage was about 5%, bacterial meningitis was about 18%, but that was essentially on par of what had already been. So we got to figure out how to not miss these, but we didn't see that there was any differences. And so this was published last year. I thought that'd be a nice update for this conference. Now, moving over to cerebral venous sinus thrombosis, we have thunderclap headache in about 10% of these individuals. Headache is also present in about 3/4. As the CT is normal in about a quarter of patients, CSF is normal in about 70% of patients, with 30% having increased RBCs, lymphocytosis, and or increased protein, or IBCs and increased protein. 40% may have elevated CSF pressure alone. And if this is suspected, we do want to get a MRI, MRV study, which is the study of choice. And anticoagulation is the treatment there. When we look at risk factors, there's transient risk factors, which may be infections, pregnancy, periprudum, physical precipitants, thrombotic drugs, dehydration, diabetic ketoacidosis, and then permanent is you're going to look at more your malignancies, your genetics, your dural fistula, so structural conditions that are permanent, inflammatory diseases, thyroid diseases. Now, moving on to arterial dissection. So a thunderclap headache occurs in about 13% of patients that have arterial dissection. That's one of the things we were talking about. I think one of you, when that intermittent case, like when we were looking for a dissection, that's important, but even here, this is more in the thunderclap sense. The CT and CSF is usually normal. The MRI, MRA are diagnostic procedures of choice, and the treatment is controversial. However, because anticoagulation versus antiplatelet therapy. However, there's recent evidence with the CATIS study that shows there's really no significant differences between recanalization rates, stroke recurrences, which were low in both groups, and or the early recurrent events. And so you like to use either one. So it's not controversial. They just seem to be equally efficacious as far as what we know now. So this is some recent updates of that study. Now, pituitary apoplexy, acute clinical syndrome that has headache, visual changes, ophthalmoplegia, altered mental status, variable endocrine abnormalities. You got hemorrhage, which we would see blooming artifact, and I'll show that in T2 when we see this on the MRI. And there are pre-existing macroadenomas, so microadenomas we may see a lot, but macroadenomas is very common. There are clinical risks that are involved, which is trauma, open heart surgery, anticoagulation, conventional angiography, Sheehan syndrome, and others. And treatment is with surgical decompression or steroids, but complications, again, with this is very serious with coma and death over weeks. And this just shows a little bit of the acute features on T1, you see iso hyper intense, T2, hypo-intense of the pituitary gland. You may see that blooming that I was talking about on T2 artifact if there's hemorrhage around the pituitary. Restricted diffusion may be early signs of hemorrhage. You may see ring enhancement or even dural thickening or mucosal thickening of the sphenoid sinus. Now, reversible, y'all hanging in there with me now? Everybody hanging in there with me? Okay, all right. I didn't tell you we were going on a journey, right? So we're going on a journey. So reversible cerebral vasoconstriction syndrome, RCVS, is most commonly precipitated postpartum, but also with the use of vasoactive substances. Cannabis, cocaine, SSRIs also been known to do it. The binge drinking, nasal decongestions. What we see on imaging is strings and beads on imaging. It may result in posterior reversible encephalopathy syndrome, subarachnoid hemorrhage, increased intracranial ICH, and ischemic stroke. And we treat this with calcium channel blockers, whether IV or PO. So, in summary, thunderclap headache, we really want to ask about the mode of the headache, especially in patients presenting with a headache or presenting to the emergency department, and know the differential diagnosis of thunderclap headache as well. And then all patients should really be aggressively evaluated in this case. So I'm going to move over to a few other ones, secondary headache syndromes, idiopathic intracranial hypertension. Dr. Friedman published this about 12 years ago, where we're looking at papilledema, like a revised criteria both in children and adults, where we're looking at papilledema, normal neurological examination, except for cranial nerve abnormalities is normally normal. Gaddon has an MRI, normal CSF composition, opening pressure of CSF is 25 centimeters of waters in adults and 28 in children. If they're not obese or sedated, then down to 25 centimeters or 250 millimeters of water CSF. Now, when we look at this syndrome without papilledema, you must have an abducens palsy, so cranial nerve 6 palsy. But if we don't have papilledema and don't have a cranial nerve palsy, then you need more of the imaging signs. And so he had 3 of the following. So empty cella, flattening of the globe, distension of the perioptic subarachnoid space, and tortuous optic nerve, transverse venous sinus stenosis. we rarely see PTCS without papilledema. So it's uncommon, but it can be seen, and these are the different diagnostic criteria. This is what I was talking about as far as on what we may see on imaging with the flattening of the globe, distension of perioptic subarachnoid space, the tortuous optic nerve, empty cell, and transverse venous sinus stenosis. So headache occurs in about 90% or over 90% of people with the disorder. Is usually daily, usually bilateral, retroorbital, can be more severe in the morning, and more often with the migraine phenotype. That will actually come into play in just a few slides. So there's also transient visual obscurations, intracranial noises, swishing in ears and things like that, diplopia and sustained visual loss. So do we get an MRV for all? I think Dr. Freeman and colleagues' suggestion was yes, right, when possible, especially when it's an atypical presentation or people are not responding to treatment as we think that they should. So we want to kind of look at other possible underlying causes, may even get CSF analysis for cytology as well in those cases. There are secondary causes and risk factors with this cerebrovenous abnormalities, CVST, hypercoagulable state. I'm not going to go through the whole list, but vitamin A and retinoids, antibiotics, withdrawal from chronic corticosteroids, hormones, chlorothiazide, endocrine disorders, hypercapnia, and some other syndromes. And I think when we think about this, it's kind of when we look at management, right? If we can see what those risk factors are and develop those management. Now, when we're looking at management here, not all patients need to be treated. Actually, they really want to preserve the vision. That's the goal. Everything is really dictated by vision. And even when they present in the emergency department, you usually call neuro-ophthalmology or ophthalmology to come and take a look. Team approach is important. So neurologists, ophthalmologists on an outpatient level, obviously in the ED, we're going to be depending on some of our ED colleagues to coordinate the management. Medical treatment, first we want to eliminate contributing factors and causation factors. Low sodium diet has been shown to be helpful. Weight loss, and I did want to highlight, I put it in bold here, the glucagon-like peptide receptor antagonists, because this is a big thing on these now. And it was suggested that these are very promising weight loss options, but preliminary studies have not demonstrated considerable impact on papilledema, headache, and vision. And then women with high IIH have high rates of pregnancy complications, partly related to obesity, but the recommendation of weight loss during gestation and pregnancy is controversial. We want to control the intracranial pressure and also headache management. And I did want to highlight this article. It was published like 2 years ago or so, where it was looking at the diagnosis in IH and long-term outcome in pregnant women. And the diagnosis of IH in pregnant women was rare, but it was associated with more severe papilledema. The long-term visual outcomes in IH was analogous in respective to the timing of the pregnancy, but the researchers suggest that so that's assuring, but we do need vigilance for our pregnant patients. Obviously, the case I'm talking about is a gentleman that is not pregnant, but I thought this is just really something really good to know. The headache management, so we're visual headache, right, and some of the associated symptoms. There's going to be symptomatic management. There's also preventive management. We want to avoid valproate, steroids, and tricyclic antidepressants due to weight gain, opiates, or long-term steroids for sure. Beta blockers and calcium channel blockers may reduce perfusion to the optic nerve head. So we want to be careful on that. And when you look through this list, I said anti-CGRP medication, I put a question mark there. Why did I put a question mark there? I'm glad you asked. All right, because recent studies would suggest, there's cases that suggest that calcitonin gene-related peptide antibody treats headache in patients with active IH. There was also a study that's compared healthy controls to those with IIH and saw that there was increased CGRP plasma levels. And then there was another study that was recently published, that's published last year, that showed that the plasma level was increased and elevated in those who had a migraine-like phenotype with their IIH. And so that's why I wonder, hey, is this something that we're going to move forward to again, not FDA approved for this particular diagnosis, but that's where the phenotype matters. The role of steroids, I said not long-term steroids, right? The role of steroids really is just to buy time. They work initially, but not recommended for chronic treatment. Diuretics are basically used essentially in this order with acetazolamide, furosemide, trimiptorine, and spironolactone, but we would be careful if we're combining them. I wanted to just move to surgical treatment option. Again, as you see in blue, we're really trying to protect vision in this case. So progressive vision loss, despite maximum tolerated medical therapy, severe vision loss at presentation, severe vision loss, and unreliable follow-up. Procedures that were commonly used is optic nerve sheath fenestration, LP shunt, and VP shunting. However, there's a recent systemic review that looks at the surgical treatment options, but also different papers that has been published with venous sinus stenting in idiopathic intracranial hypertension. And so overall, surgical management, so CSF shunting is the most frequently procedure performed for medically refractory IIH. It provides immediate improvement in both headaches and visual defects, but it's associated with high failure rate and high failure and complication rates. The optic nerve sheath fenestration is modality that has been proven to be effective in halting further visual deterioration and improving visual outcome, but it's not as effective as we would like in treating the headache disorder. And then the venous sinus stenting provided, based on this review, provided the best results in terms of headache resolution and visual outcomes. The 1-year failure rate and the late failure rate of VSS was substantially lower than expected rate with the CSF shunting, and the complication rates are also globally excellent. However, the risk of cortical vein perforation and severe hemorrhage and death are really unique to this particular procedure. So I'm going to move on to just a few more and just listing these secondary headaches. So spontaneous intracranial hypotension. This is criteria coming from the International Classification of Headache Disorders. Third version, and I believe a fourth version is in process. So what you were saying, with actually getting more, as we get more evidence, our classification and things get better. So it's really important. So if you have cases and things, report those, please. But this is a low CSF pressure, less than 60 millimeters, and evidence of CSF leakage on imaging. The headache has developed in temporal relation with low CSF pressure or leakage, or led to its discovery and not better accounted for by another diagnosis. And there's some of the MRI findings that we will see with the sagging, and we see venous distension signs and different pachymeningeal enhancement. So in CT of the head, you'll see the subdural collections, cerebellar tonsillar herniation to foramen magnum. You'll also see with MRI of the brain, I'm just going to put these up real quick because my time is escaping me, that you'll see these. We're good? All right, thanks. He said I was good, so he's the boss. So, but anyway, you will see some of these different signs on some of these different imaging modalities. I wanted to talk about giant cell arteritis, or GCA. This is also really important. This is urgent, emergent headache. It can be, depends on when it's diagnosed. And for reasons we'll talk about in just a moment. So giant cell arteritis, to get a headache secondary or attributed to giant cell arteritis or GCA, the GCA has been diagnosed. It has to have at least 2 of the 3 that the headache result developed in close temporal relationship, or the symptoms happen, or has led to the diagnosis or discovery of GCA. They have either of the 4 of the following: that the headache worsened parallel and worsening of the GCA, and and that is, or that is significantly improved within 3 days of high-dose steroid treatment. And then the third of the two that needs to be satisfied is that the headache is associated with scalp tenderness and/or jaw claudication and not better attributed by another diagnosis. So here are just a few pearls about this one, because it was interesting. I was having a conversation with one of my colleagues here. I'm having a lot of conversations with colleagues here, but with one in particular, we were talking about geriatric populations and things like that, and what do we need to do as far as even with treatment and their headache diagnosis, and even when it's urgent or emergent. And so just a couple pearls. So the result of inflammation of the cranial arteries, especially the branches of the external artery, is usually what GCA is. Any recent persisting headache in a patient over 60 years of age should suggest GCA and lead to appropriate investigations. Repeated attacks of amaurosis falx is associated with headaches, are strongly suggested with GCA, and should prompt further investigations. Tests, including non-invasive imaging in conjunction with clinical expertise, are current gold standard for the diagnosis. And also fast-track pathways, which has been shown and has been done to actually reduce the morbidity and that we see with GCA, and also reduce some of the cost-effective, and reduce the potential for overtreatment in those suspected to have GCA. And tocilizumab is an IL-6 inhibitor that's licensed in English for the treatment of GCA. And this is important because it gives a little bit more pathophysiology to the disease. And the more we know about pathophysiology of the disease, the less stigma we have with headache disease, and then also the more we can treat and better serve our patients. Just a couple more pearls here. The risk of blindness is a result of the anterior ischemic optic neuropathy, which can be prevented by immediate steroid treatment. And it's important because the time for visual loss from one eye to the other eye is usually less than a week. And so patients with GCA are at risk for stroke and dementia. And then there may require serial biopsies of the temporal artery due to skip lesions that we might see histologically. So here are a few. This is a table of dangerous causes of headache. I didn't go through all of them. My time won't permit me to go through all of them. We covered some of them, especially with the thunderclap headache. There's a couple of pages of this. I do have the resource there if you want to check it out for yourself, right there in the corner there. There's several headaches, again, that I just didn't have time to cover today. And I want to go through just briefly treatment of migraine disease in the ED in adults, because many people present with migraine in the ED. And so in 2006, the American Headache Society had a consensus statement of acute treatment in migraine. And then even though the reference says 2023 protocol for the update of acute treatment, that was the update based on that consensus statement, but that was just published last year. We don't have the update just yet, to my knowledge. However, there was a systemic review and meta-network analysis of the effectiveness of parental agents for pain reduction in patients with migraine presenting to the emergency settings. And I have these charts here just briefly. This is in looking at primary outcomes, and what you can see, this particular study, there was 28 settings and over 2,300 patients with this. And what you can barely see, and I don't have a pointer or what have you, but the top two, as far as primary outcome for parental, were anticonvulsants and actually magnesium sulfate, followed by combination therapy, when you use a lot of combination therapy in the ED, and then neuroleptics. And so this was in pain intensity in adults presenting. And then finally, the secondary outcome was pain relief. And what we see is that neuroleptics, and this was over 50 different studies, 50 different studies with over 6,500 patients or encounters where neuroleptics and combination therapy had the highest probability or best probability and ranking in odds of being helpful for pain relief. So I just wanted to do that. That was published last year as well. So just wanted to put that out there as far. So I'm looking forward to the American Headache Society to in the group that's coming up with this, so that we know a little bit better of what's best, what's recommended, because there are updates. We just don't know exactly what they are yet. So back to our case briefly in the next 2-3 minutes. So our case, remember our case, we started, he was, having intercourse, had this abrupt headache that was lasting about 3 hours, where there's clues for differential diagnosis. So that we would consider that a primary, or we would consider that exertional headache. And we have to find out if that's a primary or secondary exertional headache. And so for primary exercise as a sexual headache, there's some clues like less than 40, more than one episode, if it's male, if it's lasting less than 24 hours, or no other symptoms. For secondary exercise headache or sexual headache, if there's age is greater than 40, only one episode, females lasting more than 24 hours, and other neurological signs and symptoms. So this is the diagnostic criteria for primary headache associated with sexual activity. And has at least 2 episodes, so this was his second episode. So he has had at least 2 episodes of the head and neck pain, fulfilling the criteria B through D, which is brought on or occurring during sexual activity. They can have either or both, where it's increasing with the intensity of a sexual excitement, or explosive intensity just before or with orgasm. And it usually lasts from 1 minute to 24 hours with severe intensity, but could have mild intensity that kind of lingers for 72 hours, and not better accountable for any ICHD-3 diagnosis. Just a couple of notes that was actually in the criteria. First, if there's multiple explosions during sexual activity, that the headache should be investigated is the RCVS, right? So headache is secondary to reversible cerebral vasoconstriction syndrome until proven otherwise. And then on the first onset of any headache with sexual activities, they suggest that it's mandatory to exclude subarachnoid hemorrhage, extracranial arterial dissection, and reversible cerebral vasoconstriction syndrome. So in our case, we went through a thorough exam, including fundoscopy, no deficit, brain MRI, no abnormalities, treatment, indomethacin, 25 to 50 milligrams, 1 hour prior to the intercourse is usually very effective. Sometimes people try beta blockers, as was tried on him before, but cautions for impotence for that. And then also calcium channel blockers have been used. And then lastly, the aneurysm question of the wife, right? We want to make sure that we're taking care of the whole patient, whole environment and everything. So known familial barrier aneurysms, the chance of aneurysm in an individual may be 4 times greater than the average risk. And then screening questions and close observations with new clues and can further the workup, or further workup as adequate as needed, maybe with a CT angio. So this is not our patient with the aneurysm there. So with that, I want to thank you for your attention. I know that we'll have questions coming up a little bit later.